Okay, now we're good. Is my volume adequate and clear?
Your volume is perfect.
Okay, good. I'll go without the external speaker then.
Alrighty. All
Microphone.
right. Well, let me give you an introduction and then I'll let you take it away if that sounds good.
Great.
Okay. All right, folks. Thank you for joining us today. Today we have Sallie Rediske, a master physical therapist. You were a former physical therapist who specialized in complex chronic conditions, including ME/CFS, fibromyalgia, and hypermobility disorders. She was board certified in women's health physical therapy and brings both clinical expertise and lived experience with ME/CFS. So, Sallie, please share your wisdom and experience and knowledge with us.
Thanks. Thanks for inviting me. And this is a very um complex topic because there's some real positives about rehab therapy, and then there's some very contentious and very even, I would say, traumatically triggering aspects for many patients with ME and probably now long COVID when it comes to rehab therapists. And I feel like there's an old funny saying that says, nobody can speak about my sister a certain way, but I can call her whatever I want. And I feel like I have a little bit of leeway in how I speak about my fellow therapists. I'm calling them out a little bit. I'm going to reserve a little bit of diplomacy, but I do hold them to a standard that I believe they should be um, performing at, and I know that they can. And I also think that patients, by educating them on really what the services could be and should be, they can go into a situation and be a lot in a much safer situation and come out probably with better outcomes. So that's what I hope to share today.
Okay.
Yeah. Do you want me to just go down the list of questions that we talked about earlier? Would that be a way? Or you want
That'd be fine.
Okay. So we kind of came up with some questions, and these are the questions that when I think about my lived experience with ME, which is very long, and then I've witnessed these patients of mine that I worked with, most of which who never had diagnoses. They just suffered and tried to navigate their own conditions. And they would end up in my office because the doctors didn't know what to do with them. And I just had basically had patience for them. That was the key, was that I tolerated their stories and tolerated working in a slow, methodical way. So, why would somebody want to go to a PT or an OT or a speech language pathologist? That's the key for somebody with ME/CFS. And so, even before we ask that question, I think that it's really important to actually explain what these professions are and what they do. So PTs are the most common profession of the three, and they're pretty much, you can find them in almost every community, even small ones across the United States. And their goal and their job is to treat functional movement losses or impairments. And so everything that their lens that they look through is all about movement. And then nowadays they're graduating with what they call a doctorate in physical therapy. So when you see somebody with what's called a DPT, that means that they have met the minimum requirements to graduate from a PT school. It's not the equivalent of a PhD, where that's an extended academic degree. It's a entry level program that allows them to take the licensure exam. Um, the OTs are the second most common of these professions, and their lens that they look at and that their job requires them to do is looking at things through what would be considered how do you perform your occupations? And the name itself is kind of weird because, and I personally think that they lose a lot of patients because of the name. Um, because a lot of people think that an OT is simply helping people with their paid job. And that's not true. An occupation to an occupational therapist is their anything that makes someone's life meaningful, or um, possible or fulfilling, um, fills the needs of your life, like food and security. And so it could be your paid job, it could be a hobby for a child, it could be play, could be going to school, it could be all kinds of things.
I
And
would think, just a quick
mhm,
question for you.
yeah.
A physical therapist, wouldn't they be trying to accomplish the same things?
Yeah,
Or
that's a good question. They overlap. It's like a Venn diagram that almost completely overlaps on each other. The lens, though, that they look at this is really can be very different depending on which state you work in. And so an OT looks at it from they do it a little bit more usually from what's called a public health model, which is they're looking a little bit more holistically, and they're looking at more of the ramifications of like socioeconomic, um, social, environmental, um, sensory. And this is one of the reasons that they tend to be more um, a profession that's already more adapted to the needs of an ME patient, because this is already kind of the checklist of what people with ME needs. Whereas a PT, actually, PT is usually designed more on the medical model, which is identify a a structural anomaly or a pathological problem where there ends up being a diagnosis of a singular sort of thing instead of seeing it systemically or even holistically the whole body. And then they end up treating that through usually exercise. Exercise is definitely their preferred approach, but they have a myriad of other means include and that's where then a lot of that overlaps with OT. Um, but it's that frame of reference of how they start looking at it that really differs. So it's a really good question. And then what's really interesting is when you get into um especially rural states, um the the laws in a lot of the rural states have been written so that there's very little differentiation between these professions. And so what you just asked was really important because they're trying to make it so that people who live in a rural community where there might be an OT but not a PT, a person could actually get services. They might in a bigger community go to a PT, but in this small community, there's only the OT, and that they make it so that they could go to the OT. And so it's really important that the messaging get out when we're trying to educate these providers. What I see happening is there's this real drive to educate OTs in particular because they really do start from a better spot about ME. But if we all focus on, oh, OTs are really kind of the better provider, what's going to happen is the PTs are all going to be like, well, that's an OT problem.
hmm,
We don't really have to pay attention. And the problem is, though, the PTs are the number one populous profession by far. And so more patients end up in the care of a PT. So we really need to have everybody educated equally and to understand that their skill set is equally qualified to work with people. And that rural model is actually much healthier and better for people with ME than the urban models in the bigger states where people end up where the professions separate the professions really defined in a defined way. So
is the
kind of a
is the
long.
training for being a PT equivalent to an OT, or is there a difference there?
It's different. The PT training, like I said, they've gone into they've mandated that the every program is a DPT program now. and in the OT programs, I shouldn't say they made a choice to not go to the mandated doctorate program. So some of them are masters and some of them are doctorate. And they but the quality of the providers is not, you can't say that one is better than the other. Um the 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 approach, though, I would say that physical therapists come out of school with a much higher understanding of the biological components of the human body, the anatomy, the physiology, whereas I would argue that the OT comes out with a much higher understanding of the psychology and the cognitive components of
Mhm.
the human experience, and it shows up in how they treat both of them, doing things a little bit differently.
Okay.
Yeah. So and then we have the speech therapist who, to me, honestly, I think they're the best kept secret in all of healthcare. And they are the third most common of the rehab providers, and they're the speech language pathologist, and they are master's level providers. They don't entry level is not a doctorate program. Um, they have a very unique qualification for people with ME, and I think are very, very much underutilized by people with ME and long COVID. Their specialty, or their qualification, is to focus on um, anything to do with communication, swallowing, anything with this right here. And and the communication part, I think, is so important to understand that it's not just like like I'm talking right now. It's all of the components that go into communication. And that for me to even say that, it's far beyond my understanding of all that goes into that. And to listen to one of these people talk, it just blows my mind how much goes into communication. So all the preparation that the brain does to organize thought, to decide if socially it's an appropriate comment, and to organize it in the order you want it, and to form the words. And I mean, it's just amazing what they do. And they're really great at doing things like helping people organize some of the complexities of managing all the medical stuff that we have to deal with. And and then you get into the other part of, like, for the severe and the very severe, with nutrition access through, swallowing and feeding tubes, and even, slightly less involved people with mastication or chewing difficulties and things like that. It's an amazing profession, and really, think it's underutilized. They also have there's a most most people strive to get their, what they call their 3 Cs, or their CCC credential, which is um it's a indication that they've taken a much higher level of training, done a mentorship and or an internship, and some um ex pretty pretty high level testing after the internship. And when they do this, it gives a pretty good indication that they have a high level of understanding of the cognitive component of things. So kind of somebody that, if somebody's with ME is looking for someone, that's, you want to look for somebody that's got the CCC marker after their name. So anyway, those are that's a rundown of the actual three professions. But then, why would you actually go to one of them? That's the key, because it can be frightening for a lot of people to take on another medical person that might gaslight or might hurt, or gosh knows what they might do. And especially when they have the reputation that some of them have. I will tell you this: I have a friend who is a PT, who is a long, multiple decades ME survivor, she calls PTs a bottom feeders of healthcare. That's how they are perceived, and they have the opportunity to change that perception. It's up to them to start learning. Um, so there's three basic reasons that people would go to a provider like this. The first is if we're lucky enough to find a provider who is actually trained in post-exertional malaise and is going to be able to help us directly manage PEM, to hone our skills and to optimize managing PEM. And then the second one would be that we have a pretty good handle on our PEM, but we have some other form of a comorbid issue, like maybe hypermobile Ehlers-Danlos, or we have chronic migraine, or we have POTS, and we need help with that. And then the third group is where we have something that is unrelated. It's not something that co-occurs with ME, but it has happened to us, like we might have been in a car accident, or we might have had to have a total knee replacement just unrelated to ME, and we need help getting recovered from that so that we don't have a long-term disability related to that problem. So in all three cases, we need somebody that understands PEM, because if you don't have the energy system protected and taken care of first, then it does not matter what these other conditions are. You will damage yourself if they push you too far past that energy capability, if they're doing total knee rehab. And so the person has to understand PEM. They don't have to be an expert in it, but they have to understand it. And if they're doing cognitive rehab um for a stroke, say you had a stroke and you have ME. Fortunately, most stroke therapists understand energy limitations, but they have to understand PEM to be able to work with somebody with a stroke. So there's all this stuff that has to be layered in, but PEM has to be the first baseline of understanding for them to operate from. Um, so those are that's how somebody would end up in somebody's office. And then we talked about you know what would somebody do when you get there? Like, what is the reasoning? Like, how would they treat me? That's a big thing. So um the OT, like I said, is already, I think, kind of initially prepared, better prepared to help the ME client. And if they're coming in for PEM instruction, help with pacing and stuff, the OT is already going to just slip right into their natural role. And even if they're not an expert in PEM, and they're already going to start doing stuff that they're really familiar with energy conservation and stuff. And they do, home assessments. They have all kinds of tools for looking at your environment, looking at your job if you're still able to be employed, um, looking at equipment that can be brought in, and considering not just, like some people just throw equipment at people, but a really good OT would look at, is this equipment actually even, what's the trade-off? Are you getting enough benefit by using this piece of equipment for the energy consumption of having to learn to use it or to physically manipulate it? Because there's actually a trade-off. You don't always just get a benefit because you're using a piece of equipment. And then the speech therapist would do basically the same sort of thing, except with the speech and the swallowing. They would be looking at, what are your communication skills? What are your communication challenges? And how can we break that down and give you supportive tools in all kinds of different ways? Sometimes they would be tech, sometimes they would just be, um, you know, timing ideas, or it might be post-it notes, or different ways of ordering your work day. And then um, the PT basically would be functioning a lot more similarly to the OT than they would um, the traditional PT. They would be looking at a lot of the same things. The the PT tends to be the one that is using more of the tools like heart rate pacing. So they would be the one very often that is initiating heart rate monitoring, where you're using a gadget on your wrist or your arm to help with heart rate pacing. They very often are the ones that are doing more POTS oriented stuff, where non-pharmacological things like um, compression tights. They might actually develop a um a program for helping helping return fluid of the body that still it would be considered exercise, but it's within the framework of fitting within the safe guidelines of ME for somebody with POTS. Um, so those are some ideas, and then there's a group of people in that are increasingly showing up in all of the groups, all three professions, and they're called integrative therapists. And um, they um, trying to think about how to say this, because there's always been integrative therapists, but it's become much more of an issue where they market themselves as integrative therapists, and there's not like a degree or a certificate in the therapy world that they get when they become an integrative therapist. The therapists that are really marketing themselves this way are going outside of the professions and getting usually nutrition degrees to go along with their PT, OT, or speech language pathology degrees, or they are getting wellness coaching certifications, something like that. And they're taking their therapy knowledge and putting it with these wellness programs and this whole body training, and offering this different model of therapy. And so that's a whole nother realm. But there's a group within there that's kind of like some of them have been long practicing. Most of them are PTs, but they do highly skilled manual therapy. And these people are they're taking that knowledge of the body, the anatomy and physiology that they have, and they're incorporating it with these really incredibly highly tuned manual techniques. And they're really hard to track with when they try to study them. It's very hard to come up with random controlled studies when you're touching someone. So it's very hard to document whether or not they're scientifically helpful or not. But um there tends you do hear a lot of positive feedback in the complex chronic world for some of these techniques. And they have to be gentle, and the people that do them are usually very backed up with clientele, and they usually have really extensive reputations for what they do. And it's not only just pain that they're alleviating, but the people feel like their digestive systems function better, their breathing is better, they're releasing they're improving movement. That's how they manage to do it in the PT world, because again, they're fixing movement issues. So that's something to look for. Very often they're only cash pay, so that can be tricky. But it is something that is kind of a little dog leg off the traditional PT world, but it is something that I know quite a few people in the ME world get help from.
Yeah, there's probably a couple different versions of that. I know
Yeah.
that I can't remember the names of them. Like, is it manual release therapy or something like that, where they're working on the connective tissue?
Yeah.
Trying
Yeah.
to,
So myofascial release. Yep.
that's it,
Yep.
myofascial release.
Yep.
And then isn't there also there's a version of lymphatic drainage kind
Hmm.
of
Yep.
thing?
Yep. Yeah. So there's the myofascial release is one of those techniques. Lymphatic drainage, which is specifically, I mean, lymphatic drainage has many different um intentions. So there's, it's like here's that title, and then there's many reasons and purposes you do it. And then off one of those is specifically the Perrin technique, which is a form that was developed for ME and now is being used with long COVID. And then there's techniques like craniosacral therapy, which is a technique that's generally very well received by people with ME. Um, Another one is called visceral mobilization, which again is it's an organ-based fascial release. So working on the connective tissue around the organs. And it's working on, the concept behind it is that the connective tissue is stuck because of all this inflammation. Things get sticky and stuck, and then the organs get stuck and cause pain and dysfunction. Um, so there's quite a few of them, and it's and then there's some people that do some other work that's specifically nervous system oriented, so neural mobilization. Some people that do some amazing things with the spinal cord itself. I mean, it's amazing the things that they do, and it's really frustrating because having lived with this illness for so long and worked with people who struggled so much, we want things to be obviously evidence based, and we want to not be manipulated by con people for sure. But there's also um, the ability for people to go into a situation with their eyes wide open, and as long as they have the information and they look at the situation and consider the risks, and that having a manual therapy appointment with somebody is a fairly low risk situation, and you try it out and see if it works, and determine what the consequences might be. Okay, that's fairly low risk. I don't, I can make that personal choice for myself, versus other things that people may find themselves trying that might be higher risk. And so it's just one of those things that I feel strongly about, that I don't want it to be pushed away just because we can't come up with a way to do a random controlled study on it. you know
Hmm.
um
I know this isn't falling quite into that, but I've seen uh, neck uh, therapies done by chiropractic that I would not want to. I mean,
yeah,
that's just
yeah,
scary.
yeah, exactly, exactly. Yeah, yeah. And so when somebody's putting like craniosacral, one of the things is, it's a kind of a mind bender. Like, how can something so light do what they claim? But I don't know that I really have to, go there and understand that. If the patient gets up and says, I got a whole week's worth of relief, okay, maybe all I did was stimulate the parasympathetic nervous system.
Yeah,
Okay, maybe that's good enough for me. But they're talking about, literally, when they train you, they talk about using the touch of a nickel, like you're holding the weight of a nickel. So I know I, am not going to hurt someone by putting the weight of a nickel on someone.
right.
Whereas manipulating someone's neck, absolutely, that's a high risk, situation. So there's a trade-off that has to be considered, So, um, so anyway, it's something to think about, um, and it's not for everyone, and maybe there's a psychological buy-in. I don't know, maybe that's part of it for the people that it works for. But
Yeah.
I do know that there's at least a subset of people that it helps. And so and the other thing that I think is really important to say about those people that do that kind of work, it's not just, willy-nilly kind of sloppy work. It's people, they're really highly trained and highly skilled. And even if they don't know PEM specifically, they see patterns and recognize patterns with their patients, and they know when to stop. They're not going to be like, well, my appointment is 45 minutes, by golly, now I'm going to keep working. They recognize that the person is, um, their face is changing, just like we get when PEM, when the energy drains, our face changes. They see that and they're like, okay, backing off. We need to wrap this up. And that's the kind of person you want to be looking for with that. And somebody who's paying attention, not somebody who's just
I mean, you'd think that, okay, if you're laying down in a dark room, that that shouldn't trigger PEM, but the manipulation itself, right? The whatever
yeah.
the therapist is doing kind of still can build up and create PEM itself.
Yeah, I think for some people it can, I think it has to do with the severity of the individual's situation, but I also think that it has to do with what the provider is doing. And in my personal experience with doing the work is that you have to, like, there's a um there's when they teach this stuff, there's what they call the position of ease in almost all of these approaches, and then there's a position of stretch that they teach you about. And the position of ease is is so gentle. It's taking the tissue and putting it where there's no pull on it. And I think if the person is using that approach, there's probably just not um there's just there's not much stress on the system. But if they're pulling against stuff and things, then they may kick stuff off that is too much. And it's just about paying attention, really intently to what's going on. And then the other thing is we got to figure in, you have to really step back and think about, what did it take for the person to get there? Where is this person on the spectrum of severity? Do they really need to be coming in? What was it like in the waiting room? Did they have to navigate? So it, might not even be the appointment. It might be what happened getting there that did it.
Right.
So,
So one of your questions that you had listed was how to identify and find safe providers. It sounds like that might be a
yeah.
follow-up to that.
Yeah. Yeah. This one is the one that just is like, it's almost like, I mean, I almost feel like this is like an ableist talk, like I'm like, oh, just go out and do this, and I realize how hard this is because it's there are so few people that actually understand ME. And even the people who have been trained in it, I think it's it is so, especially for PTs, it is so con contrary to what our training was, always to work with graded exercise. And oh, here I'm going to remind me remind me what you just said, but I need to put this in here. So we all know about graded exercise therapy. And so graded exercise therapy, it's a medical or it's a science exercise science term and a rehab term. And it means that um there's a preset amount of advancement in frequency, which means how often you do something, in intensity, which means how hard you do something, or in how often you do something. And did I get those right? Yeah, frequency, duration, and time, and how long you do something. So if any one of those three is predetermined before you do the activity, then it is graded exercise. So what people don't know and don't talk about is exercise is just a formal type of activity. So what is happening in rehab world is that they are trying to change the language, the way they speak, because they know that we can't stand graded exercise therapy and it's been proven unhealthy for us. So now they're using the word graded activity and they're using progressive activity. And so if we know that those words are actually synonymous, I mean, that exercise is just a form of activity, then we know that if we were to ever show up in a therapist's office and they were like, oh, we're not doing exercise, we're just doing an activity, you know, it's the same thing. And PTs are the ones that have been doing the graded exercise therapy mostly, but OTs are the ones who do activities, and they are doing graded activities with people. So we got to be careful in both places. So finding a therapist that, you know, is not doing this stuff is really, really hard because it is so ingrained in them in their training, but it's also ingrained because of our culture. Everything about our culture is more, 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 and so I think the keys that I have, like to try to find somebody is one, um uh, listen and look in chat groups and see if hear anybody, um finding anybody. There are some therapists who do some online stuff, and they can pretty much do it um most places in the United States. So if you find one of those, definitely, consider one of them. Um, the one thing about relying on someone else that for your reference is you want to let that person go for several appointments before you just jump on the bandwagon, because what I've seen over the years is that there can be this real initial excitement that somebody has about getting started with somebody, especially if somebody even knows what the word MECFS means. There's just this initial like, oh my gosh. So let the person that is telling you how great this is go for a while. They can have actually an adrenaline sort of rush because of the excitement. And to be honest, this is kind of a sad comment to make, but some of us are so isolated that when we have somebody come to our house to provide therapy, or we go to our one outing in a month and we get to be with somebody that pays attention to us, it can feel like we're getting something therapeutic when all it is socialization. And I think that's really important to note that that is not really, what we're looking for in therapy. I mean, that's important, but so I've seen people get hurt because they take someone else's advice and the person is actually not that good of a therapist, is what I'm getting at. So hold back a little bit and watch and make sure your friend does not fall into PEM because of their hastiness and their excitement. If they find somebody that has heard of MECFS once in their life. Second thing is to go online, obviously, and look at their Google reviews and stuff, and see what is out there. You generally will find a more flexible and tolerable um, system in privately owned practices. They're biggest, you also will find some really good places sometimes in hospital settings. Sometimes they're the worst, but sometimes they're really good. It just depends on which particular entity you're dealing with. The good thing about hospitals is that they take Medicaid and Medicare. So that's a positive.
Mhm.
Um, the problem with the that you really want to catch when you're looking online is what we call therapy mills. And these are entities that are pretty easy to capture when you look at reviews. And these are places that, if you look at the reviews and then you go to their website, they will not have their employees listed, their therapists listed. Um, they are very much focused on the equipment that they have on site. It's all about high tech and not the people, and not retaining employees. They're just moving people through, and they usually have many practices in a localized area. And they're just cranking out patients. Um, and then the other thing that you want to really be careful about is when you go on looking at websites, is there's when you see people who say, very often you'll find therapists will list what they treat. And you will see people treat chronic fatigue, and especially those people who have chronic fatigue listed, and people who have functional neurological disorder listed on that same website. And the reason that these people are, you need to be extremely careful with these groups is functional neurological disorder is a really hot diagnosis right now with physical therapy practices for whatever reason. And um the problem is that those therapists are not including ME in their potential diagnosis basket. They just see these symptoms and they think, oh, FND, and they don't think about PEM and ME. And so if they treat you for FND, they are exceeding your energy threshold. So they can hurt you by doing that. And a lot of people who use that term chronic fatigue think of it as in the traditional form of chronic fatigue, in the sense that you're deconditioned and um you need to reframe how you think about tiredness and the stress of the world, and you'll get better. And so those are two things that you need to be very careful about. If you see a website that says that they treat ME and long COVID, um I would call them immediately and I would ask um if they to tell what kind of practice they have, and if they utter the word PEM, I would make an appointment.
Hmm.
That would be my key, that they would be a safe place. Um, so those are the things to rule out people right away. And then if you can't find anybody, you know, or if pickings are even really more slim than you're just not getting anywhere. Look for somebody who treats POTS or hypermobile Ehlers-Danlos. And what's happening there is the people who treat POTS and the people who treat hypermobile Ehlers-Danlos are unfortunately not really buying into in the interest. They're not wanting to learn about ME, but people with ME are learning about POTS and hypermobile Ehlers-Danlos. But they are aware that complex chronic illnesses are multi-system and complicated. So they would probably be your next best bet. And what I would do is, if I were looking, I would take one of the resources that I'm really um a big believer in, is I would take the um, Bateman Horn's clinical care guide. and if you have the resources to be able to print it, I would actually print a copy and just put it in a binder or in a folder or something. And every appointment that you go to healthcare wise, I would take it with you, and I would, mark the parts if you can before you go, if your energy allows, to say, no graded exercise, and um take it in there and just show it to them and before you start your appointment, and just kind of prompt them to start thinking like that, and encourage them to get their own copy. And there's also Horn also has a rehab providers page that you can also ask them to review. You could even ask them to do that before you go into your original appointment. That would be an appropriate thing to do. So and then we also have a Facebook group that's for rehab providers. So it's PTs, OTs, and speech language pathologists. And you could take that and ask them to join. And it's full of providers who are knowledgeable and learning and interested, and have ideas and stuff. And that's another resource for them. So options to learn. And then finally, we can put the PTOT group email up. If you can't find anybody, I mean, you can actually send me the information, and I can run it through the PTOT speech language group, and we can ask if there's somebody in the group in your area that is interested or knowledgeable, and start there. So,
And I just want to point out to folks that the resources that Sally's been talking about were posted in the chat, so you should be able to get them from there.
hope that, I mean, it's a very, very and one of the things about this that really upsets me is, this puts so much work on the patient, and I'm talking about patients that are functioning at a fairly high level. This is not something that, somebody with limited um resources, or um somebody who has really impaired cognition would be able to navigate. So this is a very, very upsetting thing to me that, this is just a, um, massive part of our system that does not work. Um,
Yeah, just another part.
yeah, exactly. Yeah, yeah, yeah. So, and then the challenge is getting it paid for, so we got, so if you're lucky enough to find someone, then you got to, you've done all that work, but then you got to figure out, can you get it paid for? And one of another bane of my existence is that more and more therapists are moving to cash pay, as opposed to taking insurance. And um I think there's some that can justify why they're doing it, because some of them do work in ways that, maybe you can say that the quality of their work and the nature of how they structure their appointments puts them in a place that um makes it hard to get reimbursed, in the quality versus that, is may justify it. Um mm, I don't know. I think it's a little bit I think it's a little bit of just, um it's just too, it's just really, really hard to get reimbursed nowadays. And so people are just tired of it. And so they just are doing away with it. And there's little thought about what's happening to people who especially don't have any disposable income are living like. And it's really unfortunate. So, like I said, there's the first place, you know, most consistently that you can get coverage is in a hospital type setting where they have to take insurance. Um, and that's a real hit and miss on quality. Some of them are excellent, some of them are horrible. Um, and then there are some um, there's a movement to start doing pro bono services. Some of the professional organizations are actually promoting some pro bono stuff, but these are not going to be focused on PEM. They're going to be focused on stuff like, strokes or total knee replacement type stuff, things like that. But if you have one of those issues in addition to ME or long COVID, that might be something to look into. And those you would usually find those out about through like um uh either local hospital or maybe like a social service entity like independent living center or something like that would know about that type of program. And then we have like I said, then there's the ones that um integrative providers tend to be more cash pay. The good thing about that is very often those appointments are not traditional. Like traditional therapy used to be, twice a week for 6 weeks or something like that, 3 times a week for 6 weeks. And the integrative therapists tend to be much more spread apart. So you don't have, so maybe there is the opportunity to budget maybe a little bit more than for traditional therapy. It's a tough situation all the way around.
Yeah, definitely a challenge in our current systems.
Yeah. One of the things that I did mention that's really important, I think, is so when I first started talking about why somebody would do this, um, when you are first, when somebody's first becoming aware that there's something really going on, that just is not right, and they don't really know what's going on, or maybe they have been lucky enough to get a diagnosis. um or not lucky, but you know what I mean. They Doctors are not really trained to really write in their notes about functional limitations. And functional limitations or functional impairments are the gap between what a person wants or needs to do and what the body can safely and sustainably do over time. And so the doctor's more focused on your symptoms. So when you go in, and most patients are too, actually, they'll say, you know, I've had this I've had this terrible migraine for 4 days. But most of them don't go in and say, I've had this terrible migraine for 4 days and I haven't been able to um finish doing my taxes and taking my child to school for 4 days. They don't give a actual functional how it actually functionally stops the person from living their life. And when disability comes around, which in an ME experience is very likely to happen, there's very often a shortage of these types of records in the chart notes because that's not what people are really capturing. It's not what people are talking about. They're just talking about, I can't go to the bathroom. I can't, I'm so tired. But what does it mean? How does it play out in your life? And so physical therapists, OTs, and speech language pathologists are not considered approved diagnosticians for Social Security Administration disability applications, but they can write, their notes can be submitted and they can write letters of support. So and their observations and their testing methods are all about function. And so they capture that stuff probably better than the doctor can. And if the doctor has referred the patient to the therapist, then the therapist is communicating regularly with the doctor, and the doctor signs a little note saying that they got it. So it goes into the doctor's chart, the patient's chart at the doctor's office. So when Social Security wants all those chart notes, that goes with the file. So that report is in that Social Security file. So that's another big reason to have this down, is to have some kind of functional proof that um there is actual impairment and limitation. Oh,
Wow,
lots to think
you
about.
give us a lot to think about.
Yeah.
Um, I have more questions, but I want to open it up to the group that's here. If anybody
Yeah.
has specific questions they'd like to ask, please put them in the chat or go off mute and ask your question. If not, I'll keep going. Uh, so you mentioned that there's kind of two ways you're going to get to physical therapy. Um, One is if you have some injury that requires it, right? So not your
Hmm.
ME, but something else. But if you're currently, not dealing with an injury, what are some of the results you've seen with improvements in ME through physical therapy?
Yeah, so most people don't have, any idea really how to manage symptoms, so they aren't familiar with pacing. Maybe they've kind of um intuitively cut back and stuff, but they don't really know what they're doing with it. And then there's another group that think they know what pacing is, but they're doing it at about 75% shy of what they really need to be doing. And so it's like I always feel like you kind of have to like get your master's degree in pacing to really manage ME. You gotta be a super expert in it. And so having somebody that can help you see the reality of what you're actually doing, I think is really, really helpful, um and can help you access resources that apply to your actual life, not just random stuff, but um, they can look at what you're doing and what your circumstances are and say, this would actually help you manage better and hone it more specifically.
Okay. Kind of almost like the occupational therapy, kind of how to stay within your envelope kind of thing.
Totally. Yeah, totally. Yep.
Interesting. Okay.
Yeah.
Um, are there any electrophysical modalities that are useful?
Yeah, I think again, so it's really interesting to think of, like, everything that we do to the body is potentially going to create PEM, because the body has to process that. So again, you have to look at the potential risks and benefits. So, somebody who's on the milder spectrum, there's a lot of options for electrotherapy type stuff. So, TENS units are huge for pain relief, and they're super affordable. They're transcutaneous electrical nerve stimulation, and you can get a unit now for like $15. And they work. I mean, they don't work on everybody, but the science is there. They work, and they've been used for decades. And so those are available. Another device that's coming down in price that's really useful for some people with this the cluster of diagnoses is those pneumatic leg pumps. They're recovery pressure pumps that they came out of uh we used to use them in the hospital. People used to have to come to the hospital to use them, and then athletes started using them for recovery. Yeah, and now you can get them, for I think probably $300 off of Amazon. But those are something that, a milder patient can use. Again, the more involved somebody gets, the more careful somebody has to be that they're not going to stir up PEM by the introduction of something. Um, There's other things like I am a big believer in using like vibrators. So the handheld massager devices. There's probably about 10 years ago, the world shifted to those massage guns, and those things are horrible.
Okay.
Yeah, and so don't try that because they actually can hurt you. But if you get the cheap ones that are like $20, and especially put like a folded couple of folded towels down on the body and then run the massager over it. It's just enough to create kind of, it's almost like it's a little bit of a lymphatic drainage. So because it's just given enough, vibration that it's creating a fluid flow. And so things like that can be really helpful. And clinicians have all kinds of tools like that are available and they can do it for you instead of, you have
Hmm.
to do it.
Okay.
And they can help you try it out before you buy stuff. That's one of the things.
Gotcha. All right. Anything else you want to share with us today? This has been great.
Um, oh, here's one last thing. This is just trying to keep these words straight because oh my gosh, the word functional. So we talk about functional impairment, and there's a couple other words that get used in medical stuff that gets really tangled up with this, and it's just patient education. So Um, there's functional impairment, and we talked about that. Functional medicine, which is it's a type of medicine that is practiced, which is a whole body type of medicine. They tend to want to function focus on the root cause of it, and it's a subset of what they call integrative medicine, and they do a lot of nutrition and stuff like that. And the key here is to think that functional medicine sounds great and everything, and I'm not saying it's not. I'm just saying that you can have a functional medicine doctor who knows nothing about ME or PEM, and you can have a Western medicine traditional doctor who only gives out pharmaceuticals and they know about ME and PEM, and you would definitely do better going to the Western medicine doctor. So I'm saying, don't go by, oh, root cause, that's, the answer to everything. You got to be careful because you can get yourself hurt if they don't understand PEM. And then there's a thing called the functional capacity evaluation, and that is used in physical therapy mostly, and and then in speech, some and neuropsychiatry, neuropsychology, which is it's a broad term of how they assess someone's physical and cognitive ability, and these are highly risky tests. And they need to be produced or done only by somebody who understands PEM if you have ME or long COVID. So do not let anybody in the regular generic PT, OT, speech language world or a neuropsychologist give you what's called a functional capacity evaluation unless they truly understand ME and the consequences of PEM. And then there's the last one is functional disorders, which is like um means that you have a health condition that they cannot find a structural cause for. And that is stuff like um, irritable bowel syndrome, used to be fibro, used to be ME, things like that. And they um, used to have really negative connotations, but increasingly people are coming to the awareness that science just hasn't caught up. And so, anyway, functional is used in all kinds of weird ways, and they're not the same. So that's it.
Yes. Yeah. Thank you very much.
Yeah,
All right. Well, I appreciate your time today, Sally. This has
yeah.
been very educational, and we'll post it up on our YouTube channel so that more people can get your wisdom. Thank you very much for your time.
Thanks. Thanks, you guys. Take care. Everybody stay well.
All right. Bye-bye.
Bye.